Welcome everyone. Thanks for joining us today for our November Brown Bag in Science. We are very excited to have Susan Sigward with us today. I'm going to tell you a little bit about Susan and then we will turn it over to her. And at the end, we'll allow some time for questions. So we do encourage you to enter your questions, type them into the question box throughout the presentation, and we will definitely allow for time at the end to answer some questions. Let me tell you a little bit about Susan. Susan is an associate professor in the Division of Biokinesiology and Physical Therapy at the University of Southern California. She's also the director of the division's Human Performance Laboratory and the director of the MS in Sports Science emphasis. She completed her bachelor's degree in physical therapy at St. Louis University, her master's in anatomy from Wright State University. She then practiced as a physical therapist and athletic trainer before returning to school to get her PhD in biokinesiology with an emphasis in biomechanics at the University of Southern California. She also completed a postdoctoral fellowship in biomechanics in the Department of Orthopedic Surgery at UCLA. In her research, she uses biomechanical assessment tools to identify impaired mechanics that relate to lower extremity injury with a focus on knee injury and rehabilitation. Her work has contributed to the understanding of impaired mechanics following ACL injury with a specific emphasis on early rehabilitation. An interesting part of Susan's work is that she tries to translate biomechanical assessments from the research laboratory to the clinic by identifying mechanisms to simplify the process of using technology to identify and resolve impairments. With her understanding of how factors such as experience, age, training, and sex influence the development of movement strategies that increase risk for ACL injuries, she contributed to the National Athletic Trainers Association position statement on the prevention of ACL injury. She's also been very involved at ACSM, and she's currently the chair of the Biomechanics Interest Group. So welcome to Susan, and at this point, we are going to turn it over to her for her presentation. Again, if you have questions, please type them into the question area throughout, and we will get to them at the end. Okay, Susan, turning it over to you.
Excellent. Thanks, Lynette. Thanks for that introduction. As Lynette said, I practiced as a physical therapist and an athletic trainer for about 10 years before I went back to get my PhD, and the tools I use are pretty much biomechanical instruments to identify movement impairments. And I'm currently teaching in the program physical therapists and sports science students who aren't necessarily clinicians treating patients. So I think a lot of what we're looking at applies across the span of what I term clinicians, whether that be an athletic trainer, a strength and conditioning coach, even our clients. When I gave Lynette my title, I think I was having a stroke, and I thought that I was going to be talking about something else. But I do want to touch on a lot of the importance of translation. But I'm going to focus it mostly on looking at lower extremity mechanics following ACL reconstruction. And a lot of the work that we're doing, like many others, is attempts to look at these mechanics and how we can optimize recovery and return to play for our athletes. So let's see if I can get this going. Pretty simple. Everybody probably understands that ACL is a major stabilizing ligament of the knee, and disruption of the ligament is going to lead to instability for our athletes during turning and pivoting, cutting types of tasks. So often surgery is required to return them to their sport, and rehabilitation following surgery and the injury typically is going to run 6 to 9 months. However, there are several problems following surgery. The biggest problem that we are really facing is a high re-injury rate. One study found that up to 30% of the athletes who have had an ACL injury sustain a second ACL injury within 24 months of returning to their sport. What we also see are persistence of movement and functional deficits, and these deficits, I'll show you a few slides of other people's research sort of highlighting the deficits that I think are most important. And the problem with these deficits are that they persist at this time point of return to play and are often attributed to this increased risk for re-injury. We need to keep in mind that there are a lot of factors that may increase the risk for re-injury after your first ACL reconstruction. But there are several studies that are finding that some of these, in particular, these movement deficits, these biomechanical deficits, are increasing the odds for re-injury. One of the deficits in general that I want to talk about are loading deficits. We find that people following ACL reconstruction are underloading, so taking the load off of their surgical limb in general, and also underloading their surgical knee. And we can see, using some of the data from Paterno and colleagues out of Cincinnati, we can see this deficit in reducing limb loading by looking at ground reaction forces. Now, a double limb drop jump or drop land task is a task where the athlete starts on a box, drops down onto the ground with the intention of decelerating and then jumping up as high as they can. This is a bilateral task, often performed with force plates under each foot, and in many circumstances it's used as a screening tool for injury risk and for recovery. And this data just highlights some of the deficits that are seen at this return to play time. So at 6 to 9 months after surgery, they found that just performing this simple task, and again, this is a controlled environment, this is not what you might consider, on the field or court sport-specific task. They found that these individuals underloaded their surgical limb or their involved limb during this task. What they found in a smaller cohort but a little bit farther out was that 2 years post-op, they continue to see this underloading strategy. And these are times when we expect that a lot of these impairments related to the surgery are resolved. Specifically looking at the knee sagittal plane deficits, and that's when we're talking about knee sagittal plane deficits, the best way to highlight those are to look at a single limb task. So they're not able to shift the demands to the other limb like in a double limb task. But in a single limb task, what we see for sagittal plane deficits is that these individuals are not going through as much knee flexion range of motion, and they're also reducing their knee extensor moments, and that's a way that we can calculate the demands or how much demand they're placing on their knee extensors or quadriceps. So a single limb hop task is a task that's used a lot to determine whether individuals are ready to return to play. It's a functional task, and they have individuals hop as far as they can and stick the landing and keep control on their good limb and then their surgical limb. And passing that task means that they have hopped within 85 to 90% of the same distance. There's a couple studies that really highlight these deficits that we're seeing during this task in ACL individuals after ACL reconstruction. And Wren and colleagues, this is just showing what they found with respect to how much knee flexion the individuals are going through. And you can see in the involved or the surgical limb, they go through about 10 degrees less knee flexion during this task. But what's even more compelling is what we see when we're looking at our knee extensor moments. And I'm going to orient you to this graph because we're going to use this limb symmetry index or this ratio when we're looking at some of our data. So on the y-axis is knee extensor moment limb symmetry index, and it goes up to 1. This is taking the knee extensor moment from the surgical limb and dividing it by the knee extensor moment from the non-surgical limb. And if they were the same, we would have a ratio of 1 or limb symmetry index of 1. If the knee extensor moment in the surgical limb is less than the non-surgical limb, then we will have a deficit, and that deficit will be a number less than 1. So a deficit of 0.8 or a ratio limb symmetry index of 0.8 would be a 20% deficit in the surgical limb. So what these guys did is they divided up their subjects into those who failed the test, meaning they did not hop 90% of their good leg on their surgical limb. And then they looked at how much they used their knee extensors. And not surprisingly, we see that they don't use their knee extensors to the same extent. But what is a little bit surprising is that they have almost a 50% deficit there. So they're using their knee extensors half as much. When they looked at those who passed, so they're passing this clinical criteria, when we looked at those who passed, they continued to have a deficit, and that deficit being on a magnitude of about 20%. And that's going to be a little bit concerning there. We're looking at this underloading of the knee extensors, which is sort of typical sort of avoidance strategy. This is really this pattern is highlighted really well in the Orishima paper in 2010 as well. So if you're interested in that, there's some really great graphs in that paper to show how they are avoiding using that surgical limb. Let's put this all in the context of our expectations of recovery, and we'll do this sort of in a rehabilitation and recovery expectation timeline. We're going to consider at 1 month, 1 to 3 months, individuals are restoring sort of their normal activities. I have black and white pictures up here of getting out of a chair, walking, squatting. This is when they're getting rid of their swelling and their pain, increasing their strength, and getting back to these sort of mundane activities. Depending on what you're reading, there's a suggestion that our athletes are initiating and progressing running anywhere between 6 and 16 weeks. So we're probably talking about a 3-month time period when they can initiate running safely. And you can note that that picture is colorful because our athletes like doing the colorful things. Because following that, or in that same time period, they're going to be doing much more aggressive exercises and tasks, single limb tasks, more plyometric, ballistic tasks. And then many of the the rehabilitation and recovery programs suggest that returning to agility on sport-specific tasks and returning to sport can occur between 4 and 6 months. So if we look at those expectations and we sort of overlay our danger squares, our red squares here, the data that we just looked at, we're still seeing some of these biomechanical deficits where they don't want to use their limb or they're not using their knee as much as their other limb. And this is in this 5 to 6 month period, even going up to 2 years. There are lots of studies. I've only sort of touched on a few examples here, but there are lots of studies that are identifying these deficits at this time point. What we decided to do is instead of looking at this time point, figuring out what to do there, what we wanted to do is sort of back up and look at this early time period and see what's going on there. There's a question mark here with this underloading, but the question mark is not are they underloading early, but the strategies that they're using early in rehab, are they going to dictate what they're doing later in rehab? Is there something we can do earlier that may help them optimize what they're doing a little bit later? So what we started to do is look at data longitudinally, and it was not easy, but we had a total of maybe 15 individuals that we saw at 1, 3, 5 months, and when they started running and returned to play. And we followed them across those time periods, looking at some simple tasks early on and then some higher level tasks later. And what we quickly found out was that the patterns that we were finding in early rehab were not at all what we expected to find, and that we may need to pay a little more attention to these people early on. So we sort of focused our attention to this early time period to kind of figure out what was going on, and then ultimately going back to see how those affect long term. So I'm going to go over some data from a series of studies that Ming-Shen Matt Chen, my previous student, now a PhD, did, and kind of look at these data and highlight some of the problems that we were seeing. So again, these people were in early rehabilitation, about 3 months post ACL reconstruction, and they came into the lab and they did some bilateral tasks, easy tasks, standing, sit to stand, and a squat task. And they did it under 3 different conditions. I won't go into a whole bunch of detail here, but understanding the conditions actually helps with the interpretation of the data. So in the natural condition, they performed these tasks and they weren't given any instructions on what to do. And in fact, during the standing and the sit-to-stand tasks, there was a little bit of deception. They didn't know that we were actually measuring them. And what we were measuring were the vertical ground reaction forces, or the forces under each of their limbs. In the instructed condition, after we had done all of those, in the instructed condition, we asked them to distribute the demands, to distribute their weight evenly on both feet. So to make sure that they had equal weight on both feet while they were performing the tasks. And then finally, in the feedback condition, we gave them ground reaction force feedback, so on a screen that showed the amount of force under each limb, and they were asked to match that. Keep in mind, every time I say we, I mean Matt. I want to give full credit to all of my students and all of the hard work that they do. So we means Matt in this case. What he did is calculated the ground reaction force, and you can see that in the graph here to the right. This is during the sit to stand task, and this is the ground reaction force over time. And then he calculated the area under that, which would be ground reaction force impulse, and then compared that between limbs. So let's look at some of the data. I'll show you sit to stand and squat data. So back on this graph here, again, we have limb loading symmetry, which is that limb symmetry index. And if you remember, 1 means that there would be equal weight under both limbs, and we would have a ratio of 1. If the ratio is less than 1, that means there's a decrease in weight on the surgical limb compared to the non-surgical limb. And if it's above 1, that means there's more weight on the surgical limb than the non-surgical limb. So during the sit-to-stand task in the natural condition, what we found was that the ACL group, the little red dot there, underloaded their surgical limb by more than 20%. When we had the control subjects, and these subjects were matched for our ACL group, so they were similar age, height, weight, activity level. You can see that when the typical control person did a sit-to-stand task, they were generally distributing their weight fairly evenly between their limbs. There was obviously a significant difference between these 2 groups. So when they did perform the sit-to-stand task in the instructed condition, you can see that the ACL group was able to improve their symmetry when they focused on it, but they continued to have a deficit when they were compared to the control group that stayed fairly even at 1. And then finally, and not unexpectedly, during the feedback condition, everybody was able to do it really well. So we can see that the people following ACL reconstruction were able to improve their symmetry as they went on, but in that natural condition, when they weren't thinking about it, they had quite a bit of asymmetry. Now we see the similar results during the squat, but during this natural condition, you can see that the deficit's probably not going to be as big as we saw in the sit-to-stand task. And this is probably because they knew we were measuring them. They had to know that we were doing it. We asked them to do a squat, and the squat task is probably more similar to an exercise than a daily activity. But we did continue to find a deficit there, probably at about 15%. They were able to improve their symmetry when we gave them instructions, but there still seemed to be a difference between the control group and the people following surgery. And then, of course, in the feedback condition, everybody was able to do this well. So it seems like a pretty simple study. We only looked at these ground reaction forces, and we compared across these fairly simple conditions. But really the takeaway from this is that they can load their surgical limb, and they don't. So this is 3 months post-op, and these tasks are tasks that they're performing every day. The squat task was just go down as far as you can and come back up. You know, if you have pain, then don't go that far. So what we're finding is that, and it's not surprising that this task is actually a submaximal task, and one that they can perform with distribution of their weight, 50% of their weight in their surgical limb. But this natural or spontaneous behavior is what's really concerning. These are, again, sort of daily activities, and they're naturally sort of underloading that limb. Is that something that they're doing throughout the day? Now, of course, this is a lab study, so we can't really say we have them do these tasks, and that is what they're doing throughout the day. So Matt followed this up with these same subjects and actually calculated what they did throughout the day in daily activities. He used these in-shoe sensors to calculate vertical force, and he actually validated this, meaning that the vertical force measures from the in-shoe sensors gave us this very similar information to force plates. And he measured their daily activities 8 hours a day for 2 weekdays. And this is just an example of some of the data. He looked at, again, the impulse or the area under the curve, but this is 8 hours of data, so that's a lot of curves. What he did is he calculated when they were in weight-bearing activities. So doing a bunch of pilot data found out that when the body weight, when the vertical force was less than 20% of body weight, that was pretty much a non-weight-bearing activity. They were maybe sitting in their chair, their feet on the ground, that type of thing. So he calculated how much time they were in weight-bearing activities and then how much force they had under each limb. And what we can see here is that between the limbs, the surgical limb in red and the non-surgical limb in yellow for the ACL group had a difference between limbs. It was about a decrease in about 22% of how much load they put through that limb. And that decrease there was smaller than what he saw in the control limbs. But also note that the non-surgical limb had similar loading to the control limbs. This is interesting that we are seeing that at 3 months doing regular daily activities that these individuals are not using their limb as much. We do need to keep in mind that when we look at individual data, there are some people that are doing this well. 3 out of these 13 subjects are probably within the range of what the controls were, that little dash line. So we would consider there'd be some typical asymmetry. But also you can see that there are some people that are not doing this well at all. And when we went back and we looked at how does their daily data or their daily loading relate to the loading that we saw in that natural condition of the sit to stand, you can see that the person, let's see the diamond on the far left side of this graph, you can see during sit to stand they had maybe about a 25% deficit in force during the sit to stand, and their daily loading they had maybe a little bit more than 40%, maybe 43% decrease in loading throughout the day. Whereas when you're getting closer to those that had symmetrical loading during the sit to stand, they had more symmetrical loading throughout the day. So this sit to stand task actually was a nice task to kind of get an idea of what their daily behaviors are. Also keeping in mind that this is natural. This was sort of a deceived assessment of what their loading is. The other thing that came out of this study, and which I think is really important as far as translating clinically, is that they practice underloading throughout the day. So that practice is really critical because they're practicing it across different activities with different contexts and in slightly different demands. And if you think about training your athletes, you know, long past are the days where you just did isolated lower extremity strengthening exercises for an athlete, you know, so you're going to be challenging them in different ways. You're going to be challenging their balance, challenging them in different contexts, different positions, because that is a powerful mechanism for motor learning. And we are now looking at these individuals walking throughout their day, and they're not just getting out of their chair, they're getting out of their car, they're getting off the toilet, they're not just walking across the room, they are walking on grass and walking throughout the house, different obstacles. And Matt determined that they were practicing this for about 3 hours a day. Interestingly, enough too, you would think at 3 months post-op that they would practice this less, or they would have less weight-bearing activities than the control group. But there was no difference in how much time they spent during weight-bearing activities between the two groups. Now, granted, this was a weekday, which I don't know if I even can stand up for 3 hours during my weekday sometimes. But you can imagine in the context of how many hours are dedicated to reversing this behavior, and that would be any time that they were doing their exercises, whether they're working out or whether they were in some sort of rehab setting. Really, there's probably almost no equivalency there for that type of quality of practice of a bad loading pattern. So when we talk about translation of this information, when we're talking to our clinicians, these deficits are present in practice in submaximal daily tasks in early rehab, and they are practiced at times when these individuals can be loading that limb, they're just not doing it. So what do we need to do to fix this? The really concerning part of this is that these same deficits persist almost a year post surgery. And when I say these deficits, I mean during a squat that doesn't have any body weight, or sorry, doesn't have any weight, just a body weight squat. There are a couple studies that have shown that individuals still underload the limb or the knee, and in particular this RUS study found that there was a 17% deficit in knee extensor moments during the same task almost a year after ACL reconstruction. And again, this cannot be because they can't meet the demands of this task. The other part of this for clinicians to understand it is really difficult to see. We've done a couple studies looking at the squats, here, and at 3 months post-op, again, we saw a 38% decrease in knee extensor moments, and this is calculating this with our motion analysis. We were able to identify a 2-degree difference in knee flexion angle between the limbs. So even in a bilateral task, that compensation between limbs is 2 degrees, and that is really hard to see with the naked eye. No differences in hip flexion angle. So for clinicians to be not jumping forward to these more demanding tasks and assuming that these less demanding tasks are being performed well. And then as a client or a patient, what you need to be emphasizing, especially with these kids, is what you do throughout the day matters. And of course, we try to emphasize that in everything that they do, but with respect to their daily activities, with respect to what they're doing with their leg throughout the day, that really matters. Check our time here. And how are we going to be talking to them about their practice throughout the day? The reason, the motivation for me to actually start looking at early rehab is my lab, my biomechanics lab is inside of a physical therapy and a training facility. And I was standing outside one day on the phone, and 2 of our subjects walked out. They were twins. They both had ACL reconstruction, and they had just walked out of their rehab. They weren't in the lab at the time, and they were doing pretty well. Like, just watching them, they could walk well. They could do their squat. They could do their exercises. And as soon as they walked out the door, they started dragging their legs, and they were limping. And I thought, well, wait a minute, they just practiced a lot of stuff in there, and now all of a sudden they're not doing it anymore. So this stuff really matters. And I think I have just a minute here to touch on a few things that require a little more detail in presentation, but I just want to touch on the translation part of this is how do we as scientists help our clients and clinicians identify these deficits that I've already said are difficult to see. And there's a lot of technology out there, and a lot of what we're trying to do is figure out what of these tools, accessible tools, are really appropriate for biomechanical assessments. We've done a lot with the inertial sensors. A lot of these deficits we're seeing during gait, which is really concerning as well, very similar deficits, but that would be for another topic. But what we did using these inertial sensors is not try to reproduce a calculation of a joint angle. So what we can't do with this technology is say, hey, this is my motion analysis lab, and now I want to use these tools to do the same thing it does. we've taken a little bit of a different perspective, and what we're saying is, hey, these tools give us this information. Is any of this information, is any of these data streams, in particular for the inertial sensor, we have found shank angular velocity, so angular velocities come out of these inertial sensors. Does any of that information relate to deficits that we find important? And again, a knee extensor deficit during gait, we found that the angular velocity of the shank, the ratio between limbs and that angular velocity, really gives us information about this knee extensor moment deficit during gait. And again, that's another longer topic of how that happens. But looking at what type of information we can get on out of that, and is it important? And finally, there's a series of studies here by Krista Marie Pratt, who is also one of my former PhD students, using these inertial sensors to detect knee power deficits during the single limb loading task. And we found that the thigh angular velocity between limb ratio is related to a between limb ratio and power deficits during this task only. Trust me, we've been trying to look at different tasks, but the makeup of this task, and it's actually able to predict a deficit greater than 15%, this task, using this measurement with pretty high sensitivity and specificity. So the importance of translation and understanding that we have deficits when we can't see them, and that we need to address those in our rehab. And then the importance of translating what we're detecting in the clinic in the lab out into the clinic, whether it be using in-shoe sensors, inertial measurements, different types of cameras, etc. And then I just want to finish with highlighting all of the people that do all of this great work, former and current students. Ming Shen, Paige, and Krista Marie are former students, hence the PhD. Sarah is a current, Sarah and Sarah one is a current and a former master's student, and then some of our funding sources. And I will open it up for questions.
Great, thank you, Susan. That was an excellent presentation, and I think one of the probably best examples of how we can translate science into the clinic that we've had so far. We do have a few questions. I'm going to start with this question. This person is asking, have you done any research trying to correct these early loading asymmetries that are happening during daily activity?
That is a great question, and some of these data that I showed you today, one of them is in a paper and revisions right now, so hopefully to get out, which means that we pretty much just finished this up, and we have a few grants in. There's a few really interesting questions that we have with respect to this, especially if we have these in-shoe sensors and all this technology. Can we give these guys feedback throughout the day or at the end of the day and say, hey, your goal was to, load more during the day. Did you meet that goal and try harder or not? And I will have to say, I just did a presentation saying they can do it, so they better do it. But I also have reservations in saying that, well, yes, they can do it in the lab, but what if we made them do it throughout the day? Are they going to be more sore? Are they going to have other problems? And that's something that we definitely need to investigate and are doing for our next step. I would have to say, if we had them do this throughout the day and the consequences of that were not good, that they had pain or swelling, etc., then we need to go back to our recovery expectations and say, well, wait a minute, we can't even get them to do this symmetrical loading throughout the day without increasing their symptoms. Maybe we should be changing our expectations on that timeline. Good question.
Great, thanks. Another question, have you used portable force plates to use in a clinical setting to measure the vertical ground reaction force during the rehab phases?
Oh, I love these questions. You guys are feeding into all of this. I'm currently, with my hat of the Master's Sports Science program, there's so much great technology out there. Force plates in particular are being used a lot in sort of athlete performance rehab science at that sort of the higher level, and I think that they're great tools. I think they're really great tools. There's some problems with respect to cost, and you know, who can afford to have those for their patients, etc. But I have to, I'm going to give you a little bit more information with respect to this loading, which highlights a little bit of a weakness in what we're looking at here. But we also found in our squat paper, and this is in JOSPT, we found that the decreases, the underloading of their knee extensors is the biggest problem. And anyone who's had ACL reconstruction or has worked with these individuals is that we just have a hard time getting their quadricep strength back. And which is not surprising, I guess, now, if we're seeing that they are all day long, they're not loading their quadriceps the way that their other leg is. So that seems to be the big problem. They're underloading their knee. Now, one of the ways to measure that is, hey, are they taking the weight off of their leg? The other way that they can do that, though, is they can shift that demand within their limb. So they could be putting the same amount of weight on their leg, but they're shifting the demand within their limb. Matt's done a lot of this work, has an abstract on this, and we're trying to get this paper written. But before we have it out there, I'll give you a little secret. One of the things that we think we can do with a force plate is at least get an idea of whether they're shifting within that limb, because they're changing where they're putting their weight in their foot on the surgical limb. So it's sort of it's a center of pressure measurement, and so they're altering that a little bit. And I'm saying that because that problem of having force plates, the problem is they're expensive. I wish everybody had a good force plate or two, but the problem is that you can get cheaper force plates that just give you vertical force, so they're less expensive. They give you great vertical force, but they can't calculate that center of pressure. So one step would be to make sure that they're loading their limb. But what if we forced everybody to put the same amount of weight on both limbs, but they're like, that's fine, I'll do that, but I'm not going to put weight through I'm not going to put the load through my knee. So we're missing that piece of it. I think that this is a really quickly evolving area, and I hope to see force plates and that type of technology be a lot more accessible.
Great. We have a follow-up to that. Let's see. Do you see the extensor movement deficits in both patellar tendon graft and hamstring graft?
Oh my God. Do I have plants out there? I love this. I love this. So yes, we do. Now, of course, you consider people who have the graft taken from their patellar tendon, that they wouldn't want to be loading that limb as much. But we do not discriminate when we have subjects in our studies. And if we were to do group differences, we may find that the patellar tendon graft, and I'm only saying may because we haven't done this, we may find that they have more of avoidance than the other, than any other surgery, the hamstring or the allografts. But when we look at our data distributed across, there are people who have, have no disruption in their extensor mechanism that show these exact same avoidance strategies. And we also have people that look great who have had patellar tendon grafts. So I'm trying to stay away from dichotomizing people like that, because I think it lets people off the hook. It lets those people, oh, well, I didn't have that surgery, so I don't have to worry about that so much. But we certainly are seeing people with the autografts and allografts, or autograft hamstring, etc., that have these same deficits, and it's very interesting, very interesting.
Great. We have a couple of questions about the use of technology. So one is, how was the shoe sensor perceived during the study? And then sort of a follow-up to that is, how have developments in technology sort of improved your ability to do the work that you're trying to do?
So the shoe sensors, we've looked at a lot of them, and there are so many coming out. So I have a lot of them coming across my desk. And I have to tell you, there's pros and cons to a lot of them. So there are some that are very thin, and I think perceived me, the question may be physically perceiving them. How do you feel them in your shoe? But I can also talk to the perception of using them. But some of them are very thin, and so you don't feel them very much in your shoe. But then they have their components on the outside, more on the outside of those, so there has to be some other piece of this technology that's on the leg or on the top of the shoe. So that then, that's just a sort of a pro-con. I don't feel it, but then I have this other technology or this other thing I have to manage. And then there are some that are thicker. The ones that we use are thicker. They were probably more along the lines of, putting in off-the-shelf insole. I don't think anyone really had any complaints about the pieces of it, but these in particular were ones that we were storing the data on the device, and that was really important for us because we needed to have all of the data. And that did require a little sort of hard piece in the insole, but I don't think anyone really had any problems with that. There are some that will Bluetooth the information to you, go to your phone or whatever, and I think those may be in the future the way to go for patient feedback, because we can drop some data points through that connection and not be so concerned about it. But with respect to research, we probably need to be storing that information on the device. So there's lots of different designs here. Some of them are really good, some of them are bad. Not bad, but some of them have their limitations with respect to durability, etc. Shoot, what was the second one?
Just how the use of technology has sort of been able to improve the things you're trying to assess.
Yeah, I would have to say that this recent technology has not improved the way that we're trying to assess things. I still think, the really expensive force plates and the really great cameras are the gold standard, and they probably will be the gold standard always. So when you think of a gold standard measure, you're not thinking about improving the accuracy of the measurement. What they're doing is improving our ability to assess things outside of a lab. So in that case, there are going to be certain assumptions that we need to make from these different technologies. And again, with the explosion of these different technologies, we need to make sure that whatever this commercial device is, that it's actually measuring what it says it's measuring, first of all, and then what it says it's measuring, is that valuable to us? Just because it's measuring it, it might not be valuable. And I think the world of running and wearable sensors is probably the sort of the world that's going fastest with respect to figuring out what's good, what is the information I can use that's important, and what's not important. That's not necessarily my expertise, but I think Rich Willie in Montana is doing quite a bit of that. But I think if you look at it in the context of all these devices are not reproducing things, our gold standard measures, but they're giving us some way more information than we had before. You can think of like a catapult device or a Stat Sports. I don't want to pick a certain brand, but everybody says, oh, I want to go see if they can wear this on the field and if I can assess their cutting mechanics. Well, you can't. You can't assess their cutting mechanics. You're not going to get the same thing you get out of the lab. But boy, you sure can see what their exposure is. You can see how fast they're going, how long they're going. You can get an idea of different types of accelerations and decelerations, and that's way more information than we ever had before. So that's sort of a roundabout answer to that question, I think.
Great, thanks. We have time for a couple more questions. What are your thoughts on measuring shock attenuation with inertial sensors to attempt to identify unloading on the involved limb?
I think that there's some really good potential there. I think a lot of times that clinicians or trainers or even coaches and athletes want everything to be very sport specific. But I think you guys all need to understand that if you want to identify a deficit in particular, you need to find a task that will highlight that deficit and a task that you can reproduce. So let's say you get a measure of 100 out of whatever sensor during drop landing task. So you need to know that 100 is either good or bad, and you need to be able to apply that to the next person. What you don't want to do is then have, if you had a number of 10, you'd be like, oh, that's really good, or 100 of 2,000, that's really bad. So every time you have a new device, you need to be able to look at what that output is from that device and then put it in the context of a task that you're using to sort of screen these individuals. And shock attenuation is something that can be measured during running, and that's what I said, that I think these guys are may be very beneficial during looking at this during running, because in the good old days, the accelerometer that is in the inertial measurement unit right now used to be this little teeny device. It's still a little teeny device, but it wasn't in a fancy package, and it was put on the tibia, and it was secured there really tightly, and it had a wire on it. So back in the day, that's how they were measuring the tibial shock, or the just shock through the leg now, or the impact forces through the leg. So these sensors are going to have their limitations because they're not like practically pinned into your bone, but I believe that a lot of these companies are getting better at helping give us some good signal for shock attenuation. If you were looking with respect to ACL injury, then you may be looking at like a drop landing task, and may be able to get some good information on shock attenuation there. Again, the trick will be, what is your reference point? If your reference is the other leg, that's good. But if your reference is this person doing it better than the next person, then that you really need to figure out that output from each of the sensors.
Great. Okay, so we have a psychology question for you now. Yeah. So we know that there's a psychological component to recovery, and particularly for athletes who have surgery or reconstruction of any sort. Has anybody looked at what psychological variables, if any, might be related to some of these loading mechanics that you're finding following ACL injury?
Wow. Yeah. We literally just put a grant together to start to look at those. Now, I have to say that that's not my area of expertise, but I do know that there is rich literature out in that return to play period that is highlighting sort of these psychological factors, you know, all around fear of loading or fear of re-injury, those types of things. And I have to believe that there's going to be a similar component to that in this early rehab, because really our premise is that they developed these patterns because they hurt their knee. They hurt their knee, they had surgery, it hurts, it doesn't work like I want it to. So, and that's all true right after surgery particularly. So now I am dragging my leg around and I'm not using my knee, and now I want to walk around and do regular things. There has to be sort of a component of that. I don't know the magnitude of that influence, but yes, I don't know of anyone who's looked at it. I know, but that is something that we're very interested in. Somebody do it.
Awesome. So that means there's room for collaboration between the sports psychologist and the biomechanist.
Oh, for sure.
All right. At this point, we would really like to thank Susan for her time. We also want to thank all of you for supporting the Brown Bag series during 2018. We're going to take a break in December. We'll be back in the new year. So happy holidays to you all, and for those students out there who have their final exams coming up, best of luck to you. And at this point, here in the national office, we are going to end by thanking Dr. Sigward with a round of applause, and we'll say goodbye to you all. Thanks again, Susan.
Thank you.